My topic today will be delta hepatitis. How can we optimize the only treatment available today, which is the interferon. These are my disclosures. I will cover these issues briefly: the efficacy and safety of standard 48-week course of interferon, strategies to improve response, predictors of response, the long-term outcome, and international guideline on this specific issue. Let's start with response to interferon. We have been using interferon for delta for many years. And there has been several reviews. I just picked up this very quite recent review from Professor Gaeta, Italy. And they did a very nice review looking at all the studies, written studies on PEG interferon delta, and I'd like to point out some issues. First of all, the number of patients generally is very limited. The duration of therapy is variable. The strategies are variable. And the duration of follow-up is variable. So let's start to try to summarize what is the standard of care. I was able to identify 7 studies treating patients for the standard 1-year therapy and 24 weeks post-treatment follow-up. So 7 studies are really including these patients. The number of patients for single study is very limited, as you see, 22. The virological response after 48 weeks is 33%, and the virological response defined RNA negativity at the end of follow-up, which was actually variable for 24 weeks to 18 months, was 29%. Most of the studies were not randomized. Most of the study was not even historical control. So overall, these data are overall quite weak. And please note that the number of patients is very limited. But of course, there is a major issue here. We cannot treat 100 patients for 1 year to get 20% responses. So as we have done for hepatitis B, it's very important to try to improve the response to interferon. And there has been several studies or several strategies being evaluated in the last few years. The first strategy is really try to combine with oral therapy. In this large international randomized control study, the EDIT-1 study, they used adefovir. It was a study that's been designed some time ago, and many studies before were performed by combining interferon and lamivudine did not really provide any major results. This is a large study. Patients were randomized to 3 different groups: PEG monotherapy, PEG plus adefovir, or adefovir. Please remember that 100% of the patients with genotype 1, with 20% patient with cirrhosis, a 40-week treatment, 24-week follow-up. So 24 weeks of therapy, approximately 30% of the patients with interferon did well in terms of RNA negativity, but none on adefovir. 30 to 40% of the patients with interferon did well in terms of biochemical response of therapy, but no difference in terms of whether it was combo or monotherapy. S-antigen response in terms of S-antigen negative was minimal, very rare event. But if you consider more than 1 log decline, actually this was the surprise of the paper. Indeed, they showed that in the combo study, in the combo group, the S-antigen decline was better than the monotherapy with PEG and compared to adefovir. So basically 2 conclusions. First of all, the combination for 1 year for adefovir led to a sustained, and please remember this terminology. I will finish with a study on this terminology in about 1/3, 1/4 of the patients, and possibly a faster S-antigen decline in patients with a combo of PEG plus adefovir. And because of these data, very recently there's been another study, which is EDIT-2 study, which is the largest study so far testing 2 different strategies. One is extend to 2 years of therapy with PEG interferon plus, instead of adefovir, TDF. So a long-term combination with TDF compared to PEG monotherapy. So patients were randomized to combo or monotherapy for 2 years. Again, 98% genotype 1, 40% cirrhotics, and high RNA levels. You clearly see that there was a progressive decline of RNA during therapy, but no differences between monotherapy and combo. The same was true for S antigen levels, with very limited decline and significant ALT decline over time, but again, no major differences between groups. And indeed, when you look at off therapy, 24 weeks of therapy, which is a standard of treatment endpoint, there were really between 31 to 23% PCR negativity, 20% S antigen decline, the far more than alpha log, and 46% ALT normalization in the combo compared to monotherapy. So in conclusion, overall, 80% of the patients were able to have a reasonable safety profile despite 2 years of interferon. However, the addition of TDF did not really improve very much the virological responses because you have a 20–30% as expected compared to 1 year of therapy. But remember, there is no control group here for 1 year of therapy. Well, another possible strategy would be try to extend duration of therapy far beyond year 1 and year 2. And this is a nice US study from NIH looking at the extension of treatment with PEG monotherapy up to 5 years. Up to 5 years with a median duration of 120 weeks. Again, young patient with high RNA levels and intermediate S antigen levels. So 19 patients were screened, 13 were enrolled, and followed for 5 years. Actually, at the end, only 3 patients achieved S antigen loss, which is definitely the best possible outcome, not only in hepatitis B, but also in hepatitis delta. There was a clear relationship between time and improvement of the virologic response, ALT response, and S antigen response. At the end, however, this is a small study, very few patients, and I have to say, a very difficult strategy. Try to treat someone for years with interferon is very, very challenging, also from the safety point of view. So overall, I would say this is not a strategy that we should use in everyone, eventually in very, very selected situations. Well, there potentially be another strategy to try to improve response to interferon. One possible strategy would be to change interferon. For example, go from interferon alpha to A or 2B to lambda interferon, which is using a different receptors, and particularly in the alpha receptors are really all distributed among the body, while for the delta receptor are mainly focused on the liver. So this drug has been used in a large number of patients in C and B, and potentially you could have the same efficacy, but potentially a better tolerability of this drug. There has been a recent study testing the efficacy and safety of lambda interferon. It's a phase 2 study, which has been run mainly in Pakistan and Israel, a few patients in New Zealand. 33 patients, and again, a very few patients were treated either 180 microgram for 1 year or 120 microgram for 1 year. They were followed up for 24 weeks. RNA logs for delta were not very high, high LT, 27% at cirrhosis. So it's clear that the virological responses were more favorable in the 180 group compared to 120, 36% versus 16%. ALT normalization was better in a high-dose group, and the combined endpoint, ALT normalization plus a 2-log decline, was also better in the high group 180, 29% versus 11%. However, please know that there is no control group with PEG interferon alpha, and there were very, very few patients enrolled, 14 against 9. But what's about safety? Actually, most of the patients had G1 side effects. So most of the side effects were mild or moderate. There were some of the patients we joined this, and this was associated with mainly observed mainly in patients from Pakistan. And whether this is a genetic-driven event is not so clear, but overall, the overall message from the study is that it was well tolerated, but again, there is no control group with PEG interferon alpha. Another very important topic is how can we predict response? Again, there's been several studies for hepatitis B with the same aim, and now there's been some studies also for hepatitis delta. Again, the overall issue is that we do not want to treat 100 patients for 1 year to get only 20% response rate. Well, this is a sub-analysis of an EDIT-1 study. They look at the RNA levels over time in responders and non-responders. And not surprisingly, since response was defined by RNA, responders had a much faster decline of the RNA compared to non-responders. But very interesting, also S antigen levels had a much faster decline in the RNA responders compared to non-responders. At the multivariate analysis, if you look for the off-treatment response rate, only HDV RNA negativity at week 24, and this was a sensitivity test, was associated with a high odds ratio. And they also developed 2 different post-mort algorithms, one combining week 24 RNA decline plus week 24 S antigen decline to identify very efficiently null responders. And also they look at the RNA negativity at week 24. This was associated with very good positive predictive values, but the negative predictive values were not very good. So potentially RNA negativity or levels at week 24 are strongly associated to long-term RNA negativity. In another study from the NIH I showed you before, they were able to look at other predictors, again, RNA at week 4, RNA at week 12, S antigen at week 4 and 12. At the end, only one single variable, S antigen levels at week 12, were actually significantly associated with a complete virological response that was defined as antigen loss after 5 years, and also the virological response that was defined RNA negativity 5 years after therapy. So again, a small study, very few patients, but potentially S antigen levels during therapy as a predictors of RNA response. Probably the best study on this topic has been published a few years ago. It's a study from Italy, Dr. Nero. She looked at 62 patients treated with more than one course of interferon, followed for 5 years. She looked at S antigen levels in 3 populations, those who were considered no responders, those with partial response, and those defined as responders. Responders were those RNA negative after 5 years and S antigen negative, and not surprisingly, S antigen levels were lower in those who then achieved S antigen response, but also S antigen levels at week 24 were lower, which is potentially very interesting. They were able also to identify a specific cutoff, S antigen below 1,000 at week 24 on therapy, potentially being associated with virological response. And also they were able to link an S antigen decline with an HDV RNA decline. Of course, this is a retrospective study, and we need a prospective study to validate these very important findings. There is another possible predictor of response. As I told you, most of the studies have been generated with genotype 1. As the previous speaker showed, the distribution of genotype 1 is different from other genotypes. And this is a very recent study from Brazil, again, Amazon Basin, where they look at 22 patients. So it's a non-randomized, single-center study looking at 22 patients treated for 1 year. All genotype 3, all treated with PEG plus and entecavir. So there is no control group for another genotype, and there is no control group for another treatment strategy. So as expected, ALT went down. You see a progressive decline over therapy and off therapy. RNA did very well with a very fast decline. Most of the patients became RNA negative within 24 weeks. The few remaining positive became negative by week 48, almost no relapse. And at 24 weeks of therapy, 64% have normal LT levels. And very surprisingly, I would say, 95% of the patients were RNA negative 24 weeks of therapy. These are the best ever results. Whether it's the combination, whether it's genotype 3, whether it's a very select group of patients, maybe with very young or very short-lasting disease, I don't know. But potentially, here we are looking at an easy-to-treat genotype. Of course, we need a confirmation. There is another very interesting study, in my view, which is looking to another possible way to identify predictors. So this is a sub-analysis of the ED2 study in a large number of patients. So what they did was to look at the viral dominance. How do you define viral dominance? You basically look at viremia B and viremia delta, and then you define the 75% at the delta dominating, which is normally what we see, 17% hepatitis B dominating, and 7% with non-dominant, so similar levels of the two viruses. And what they did on the right-hand side, they plotted the RNA negativity over the RNA response and the dominance. And very interesting, those patients, the majority with the delta dominance, only 11% achieve RNA negativity at week 12 compared to 60% on those with no dominance and approximately 30% in the B dominance. So suggesting that RNA negativity can be achieved more frequently and more rapidly in those with the non-delta dominance. Although I have to say that this was not confirmed, to my understanding, in the week 24 and week 48. So potentially a new marker, a predictor marker for delta hepatitis interferon. I will not cover in detail the issue of whether these patients will do well or not after interferon, because all the studies are going the same direction. The answer is yes, interferon treatment has been associated with a significant improvement of the long-term outcome of survival. And in some of the patients, in some of the studies, even if the patients have a late relapse. So there is a strong clinical argument for treatment. What do the guidelines say? These are the delta management recommendations for 3 different guidelines. All the guidelines suggest to treat patients with compensated liver disease. There are some differences in terms of duration. APASL suggesting 1 year, 18 months. EASL suggesting 1 year, ASLD 1 year. EASL is very strong in terms of hepatitis B suppression. Give oral therapy for B if you have, every time you have hepatitis B activity. This is not the case for APASL, and this is not such a strong argument in terms of for the American counterparts. Last but not least, probably the most important study in my presentation. This is a sub-analysis of the EDIT-1 study. They were able to go back to the ED study. They enrolled 58 to the 77 patients, so 75%, and they look at the long-term outcomes, not only in terms of natural history. I will not show the data, but in terms of late delta relapse. And this is the most important information. Of the 16 patients RNA negative by a sensitive marker at week 24 of therapy, 9 had a virological relapse that was late. So a 56% late virologic relapse. This is very important because that means that we cannot define a week 24 of therapy interferon as a sustained virological response. We have to follow up our patients, and probably most of these studies are overestimating the rates of response to interferon. Finally, ladies and gentlemen, dear chairman, so off-label use of PEG interferon for 1 year is currently the only recommended therapy according to international guidelines. We should treat patients with compensated cirrhosis and chronic hepatitis. Virological response is expected between 20 and 30% at week 24 post-treatment, but please remember, probably we might face a 50% late relapse, which means that these numbers will go down to 10, 15%. Strategies to improve effectiveness has been developed, combo with nuke, extension, lambda, but there is really limited evidence so far. Predictors of response has been investigated early on therapy decline of S or RNA, apparently are very relevant, but need to be confirmed. The long-term outcome in responders is improved. However, I think we all agree that new anti-delta therapies are urgently needed, probably with interferon. Thank you very much for your attention.